I'm a cardiovascular thoracic surgeon. I see patients every day with leg problems and many other problems as well. But we all know that plaque goes everywhere in the body. If you've got blockage in the legs, you may have it in your heart, you may have it in your carotid arteries, and we have a chance to prevent heart attacks, strokes, and limb loss, and certainly loss of function by detecting plaques in the legs and treating them. So it's a total body disease, and people come in with pain in the legs, swelling in the legs every day, and as soon as they come in, my scanning procedure starts. And what I'm scanning for first is very low tech, very old school. I use my senses. I can smell the tobacco on them. I can hear what they're telling me about their symptoms. And the best way to learn about what's going on with a patient is to talk to them and let them say in their own words what they're experiencing. Oftentimes the answer is in their words as to where the problems are. I then examine them. I can use my ears, my stethoscope, my low-tech stethoscope, and I can hear carotid bruits that tell me if they're at risk for a stroke. I can hear a heart murmur, valvular heart disease. I can hear a bruit or a buzzing sound in their abdomen or over their arteries to tell me if there's plaque causing turbulent flow. And then I can use my senses of touch and feel, and I can feel the pulse in their neck. I can feel for asymmetry or unequal pulses in their arms, which tell me that they may have narrowing in, say, the subclavian artery. I can feel for an aneurysm in their abdomen, and I can feel the pulses in their legs and ankles. And very quickly, just using my senses of speech, smell, sound, and touch, I have a pretty good mental image with the most high-tech device on the planet, which is the human brain. I have a picture in my brain of what's going on inside them, and it's based on experience and just physical exam. So at that point, I usually have an idea where the blockages are, and then we do some kind of very low tech. So low tech might be an ankle brachial toe index, and this is QuantaFlow is the device we talked about the other day. It's nothing more than a little pulse oximeter that goes on the finger and on the toes, and software could be put on any laptop. A lot of primary care physicians are using it as a screening tool. I use it to follow every patient who's had vascular surgery to see what their legs are doing. And it just gives you an index between the circulation in the arm and in the toe. And
how would you compare the results or the accuracy of QuantaFlow versus the ankle brachial, the full ABI test with the blood pressure cuffs? I'm curious because I'm wondering why that device, and if people aren't familiar with QuantaFlow, I was actually fascinated by it because it's the same type of device in a sense, or the same form factor, I should say, as is used to measure the oxygen in your blood. They just place it on your finger, and in the same way, they place it on your toe.
It's very simple. You don't need a trained vascular technologist or an ultrasound tech or a vascular lab clinician to apply. It doesn't take much training. Anyone off the street could learn how to do a QuantaFlow study in 5 minutes. It does not give you a definitive diagnosis, but it can show you if there's abnormalities. And if it's completely normal, the odds are that you don't have severe disease and you can kind of move on. But it can be a tip-off. Now, the ankle brachial index, also known as, sometimes it's called an arterial physiologic study or non-invasive arterial exam. This is multi-segmental pressure, so there's blood pressure cuffs on the thighs, on the calves, on the arms, and the technician is listening with a recording Doppler, and it's giving you a waveform analysis at various locations throughout the leg. So this interpretation can tell you, hone in a little bit more on where the disease is. Is there a problem with inflow from the iliac arteries in the pelvis? Is it in the thigh or the femoral arteries and the popliteals, or is it a runoff disease in the tibial vessels? The ABI results can be abnormal or misleading, especially in diabetics who have a lot of calcific disease in their tibial vessels, which are the vessels below the knee, and they're non-compressible by the blood pressure cuffs, so they're basically calcified. So there's pros and cons to all these studies, but a lot of times insurance companies require some type of non-invasive study be completed before they'll pay for higher tech, X-ray or MRI imaging.
And what about people who are diabetic or have a lot of calcium? A lot of times you get a false negative result with the ABI-like testing.
Exactly. So this is where, understanding of the disease process and physical exam comes in. Every vascular surgeon is going to have a handheld Doppler in their office, and by feeling the pulses in their feet with your fingers, and a lot of cases you don't feel anything because they're not there, you can listen to the Doppler flow, and you can classify the type of flow based upon the level of disease, and it's pretty much going to tell you what's going on. So the Doppler is very, very valuable. The ABIs could be misleading. So it's a progression. The physical exam is very important.
And so what's next? What's some of the more advanced testing as we get into MRAs, MRIs, CT angiographies? Oh my.
I'm glad you asked that question. Okay, I'm going to share some images with you shortly, but for me, the go-to study is the CT angiogram, and that's not the go-to study for everybody. Let me see if I could share. Okay, here we go. Uh-oh, come on. Okay, there we go. So, our most powerful scanner is our human brain, and I've kind of talked about that. This is a CT angiogram, which is a CAT scan where the patients received a little bit of dye in their IV. So this is an iodinated contrast, and people have allergies to that, and we'll get into that in a second. But this is just axial imaging, cross-sectional image of this is a patient I did earlier this week, and there are the iliac arteries right here, okay? And we're coming down the pelvis. Now we're getting to the area of the groin, and on the right side, which is over here, you see that the femoral artery is occluded. On the left side, it's okay. Now we're going to continue our scan, and you see this left femoral artery looks good. This right superficial femoral artery, it's gone. But as we keep on scrolling down towards the knee, moving from the head to the knees, that artery is going to come back. You're going to see it come back in a second. There it is, and that's because we've got collateral flow or extra blood vessels going around the blockage. In this case, coming from the profunda, which is the deep branch of the femoral artery. So this is a CT angiogram. This is a very quick study, one injection of dye, and it gives us all the information we need to diagnose where the blockage starts, where it ends, where there's calcium, what the collaterals look like. And this is just a 3D reconstruction, not the same patient, but it shows you the type of imaging you can get. You can see the heart, you can see the great vessels. This is not an animation. This is an actual patient where all those axial images are crafted together and put into a 3D image. Now, the patient with the occluded superficial femoral artery who had surgery this week, you can see right here, this is the profunda. It's large, it's highly developed because that artery's been down for some time. So there's collaterals bringing flow down to the knee area, but this is the diseased vessel right here. So in this particular case, minimally invasive endovascular approach, go in with a device called the crosser catheter, recanalize that superficial femoral artery, and this is the end result. That patient has pulses in her feet, and she goes home the same day. We close up the needle stick. It's smaller than a keyhole. It's literally a needle stick. Close it up, and she walks out a couple hours later. Now, there are patients who are allergic to dye, and we can do MRI. So this is even higher tech, and the contrast agent for MRI is gadolinium. This is an example of MRI angiogram with flow. Flow is the technology that actually gives you the appearance of the flow in the vessels. So this is below the knee, and these are all normal tibial vessels, the anterior tibial, tibial-peroneal trunk, peroneal, and the posterior tibial. If you want to see disease, it's kind of cool because you can actually see all the collaterals filling in, and this gives me a mental image of what I'm dealing with, and this is in a patient who hasn't received any dye at all. Now, there are patients who can't have the gadolinium because they have kidney disease, and there's a very dangerous condition that can occur if they receive gadolinium and they have kidney disease. So we can do the 3T. 3T is the strength of the magnet, 3 Tesla, very strong, non-contrast. So this is an image of the pedal arch in the foot and the digital vessels with zero contrast, just using 3T MRA. And then, of course, this image right here, I think is pretty cool. It shows the aorta and all the vessels, and certainly you could see that iliac artery is occluded, and you could see the collaterals. And again, this is an MRA, zero contrast of any kind. So with this kind of imaging, I have my roadmap. I know the patient based on their history and physical. They need something done. The imaging gives me the information I need to take them to surgery. Here's one more modality. This is carbon dioxide, where gas is actually, injected into the patient's blood vessel, but CO2 is rapidly absorbed. So there's no problem with this going to the heart and the lungs. And it's a little bit grainy, but you can get an idea of what's going on with the CO2. We also have intravascular ultrasound, which is a super cool device. It's mounted on the tip of a catheter. And in this, my pointer's not working, but in this particular device, on the left side of the screen, you can see there that a needle can actually be distended from the tip of the catheter, and you can use it to gain access to a vessel lumen, or the opening in the vessel where you otherwise couldn't get in. So if you look in the center, my pointer's not working. If you look in the center, come back. You can see the catheter, you can see the blood flow, which is that little smudge of red at the top there. And you can then angle your device so that this needle passes into the lumen where there's flow, getting around the blockage, and then get access and do what you have to do. This is an actual patient who may be watching right now. If she is, Bobby Joe, this is her, come back. This is her CT angiogram. You could see the blockage in the aorta here. This is clot. Here's her iliac arteries. This is our mapping protocol here, and this is the angiogram intraoperatively. And we had to use that, it's called a Pioneer device made by Philips with intravascular ultrasound and the reentry needle, in order to get around that blockage, get into that lumen, and give us, a full aorta. And so she's got pulses in both feet. Talk about using your senses to palpate the patient. You can feel an aneurysm behind the patient's knee. Here's a popliteal aneurysm. This is very large and runs a risk of rupture or clotting. And, with a simple stent graft, again, through a keyhole, patient goes home the same day. This would normally require incision above the knee, below the knee, and a bypass, and, several hours in the operating room and a couple days recovery. And this patient walks out the same day. No pulses in either leg. Iliac arteries. This is an intraoperative angiogram. Iliac arteries. Here's the aorta, and just two little stents. Both go in through the keyhole. You can see this is what we call the kissing stent technique. I'm sure Dr. Alley does that every week. And the stents meet together, and you reform the bifurcation of the aorta, and you've got pulses in both feet, and the patient's going home the same day. Trifurcation vessels, down below the knee, the small blood vessels, intraoperative arteriogram. Treat that with a balloon angioplasty and restore the tibio-perineal trunk and the posterior tibial and the perineal artery. Subclavian artery, patient with no pulses in the left arm, and subclavian steal syndrome, where they get dizzy because the subclavian artery is taking flow from the vertebral artery. We just go in through a needle stick in the leg, put a wire up that, put a stent in there, and then they've got palpable pulses in their left arm, and their dizziness goes away. So imaging is integral to everything we do. Here's an aorta aneurysm with some here's the intraoperative view. You could see the long neck of the aneurysm. There's a very tight spot at the left iliac, which prevents us from getting our graft up in there. So we do an approach where we do an aorta uniiliac, run a graft from the aorta down to the iliac, and then do a bypass from the right side over the left side. And then there's our completion study in the patient. This is a little more invasive. It's a hybrid thing where we do part of it endovascular and part of it open. But again, imaging is critical to show us what we're doing. Any questions?
Oh, no, that's fantastic. So it just seems to me as if a lot of doctors like to go straight from a quick ABI or duplex, ultrasound straight to the table. But it seems as though with so many new approaches and techniques and tools that it would be critical for a patient to say, no, wait, doctor, let's not jump right into an angiogram. Let's actually stop for a second and let's do a little bit more exploration with one of the advanced imaging devices that we have available today, whether it's a full CT scan, CT angiography, before we go in there so we can have a productive and satisfying conversation about what's to come.
Absolutely. And, once we've done the non-invasives in the office, as I said, my go-to is a CT angiogram. It's one injection of dye in the arm vein, and we've got the full picture from their heart all the way down to their toes. We can talk to them about their symptoms, whether or not it's appropriate to do anything, open versus endovascular, outpatient versus staying in the hospital a few days. And it really gives us this full scope of what's going on with them. Also, we can then talk about the exercise, the diet modification. Of course, stopping smoking is gigantic, and that's how we do it.